It's the evening here and 7 p.m. Eastern time, but it's probably morning somewhere else. Thanks for coming. We have a fantastic crew of infectious disease and internal medicine physicians here with us tonight to talk about an ID case from Emory in Atlanta, Georgia. So I just wanted to quickly start with some introductions that we always do here. So just to start off, could we go through our names and say where we're from, why you went into infectious diseases, and something you like to do outside of medicine, starting with Dr. Spicer?
Yeah, so I am Jennifer Spicer. What was the second thing I was supposed to answer?
Where you're from?
I'm originally from Macon, Georgia. And one thing I really like doing outside of medicine actually is watching college football. So immediately after this, I'm running downstairs to the Pause National Championship game and hoping that kickoff hasn't happened. So please don't ruin any spoilers in the chat.
That sounds good. And could you also walk us through why you went into ID, Dr. Spicer?
Yeah, absolutely. So I went into ID. Honestly, I was a microbiology major in undergrad and just really enjoyed learning about how the environment interacts with microbiology and interacts with animal hosts and people. It was just fascinating to me that things were always changing. And I liked the social determinants of health and how that factored into disease and public health in general. So I kind of caught the bug early back in undergrad and then kind of stayed with it throughout. It's just always been the people that just really feel like my people.
That's awesome. Thanks so much. And then next we have Dr. Wilber, who's an ID fellow at Emory as well.
Yeah, so my name's Eli Wilber. I grew up in Charleston, South Carolina before coming to Atlanta for medical school and beyond. I, like Jen, got, I think, started in undergrad. I was a molecular biology person doing like single cell microscopy and just kind of fell in love with what all these little bugs can do. And then in medical school, that extended to sort of thinking about bug-host interactions. And again, likewise, found my people and realized that this was the community of providers that I wanted to be a part of when I grew up. And so here I am. And outside of medicine, my wife and I love to eat and travel. And so we like to go all over the place and explore different cultures and cuisines and trying to share that with our 2-year-old at this point.
Very nice. I miss the Atlanta food when I go to visit. And then finally, we have internal medicine PGY2, Youssef, is that correct? From Emory here. So Youssef, you want to say hey?
Hi, everyone. I'm Youssef. I'm originally from Beirut, Lebanon. I moved to the US in 2019 to Atlanta and have been here ever since. I love all things internal medicine. I love diagnostic reasoning and from all the aspects of medicine, and that is why I chose IM. Things outside of medicine I love to do. I love traveling. My girlfriend is a pilot, and whenever we have like a day off or 2 days off, we like go fly somewhere and come back the same night or the day after. And I've been exploring the US that way.
That's incredible. Wow. Also, it looks like you're being recruited to ID in the chat here by Dr. Spicer. But in any case, why don't we get started? Because I know you have a really epic case that you emailed to us. So let's get the board up here and do this. I'm super excited. Got a great audience today too. Really good, large crew.
So starting with the case. So this is a 35-year-old female with past medical history of hypertension and congenital aortic stenosis and pulmonic stenosis, status post multiple interventions, including a aortic valve replacement with a mechanical aortic valve, a pulmonic valve replacement that is bioprosthetic, along with a right ventricular outflow tract patch augmentation, and a mechanical tricuspid valve. She's presenting for chest pain and cough. So she reports that for the past week, she's been having cough that is non-productive, along with chest pain that is pressure-like, intermittent in the mid-chest, 5/10 in intensity and radiating to the back. She had fever, chills, and night sweats for approximately 1 week.
Okay. So a lot of information in this first aliquot, and I think, anytime that we're confronted with a patient on the younger side, which I would include this patient to be, it's worth thinking a little bit about, why is someone young like this sick enough to be in the hospital? And that can be because they're either being affected, and then with infectious disease, it can either be they have like a pathogen that can just really cause really bad disease and make you sick really quickly, or they could have some sort of chronic condition that makes them more likely to get sick and need inpatient care. And it sounds like this person is potentially in that second group where they've been part in and out of the healthcare system their entire life. The other thought that I'm having initially, when I hear about this history, is with the complex congenital heart history, is whether or not there's other features of this congenital syndrome that might be affecting this person's risk of having an infectious disease later on in life. Certainly just the healthcare exposure, the multiple cardiac surgeries, and these foreign materials are risk factors in and of themselves for certain kinds of infections. But I wonder if there's a larger syndromic diagnosis that might have a more direct effect on this patient's immune system and their risk factors for different infectious diseases. Moving on to the symptoms that we've heard about, fevers, chills, night sweats, and cough, leads me to thinking initially about a respiratory infection. I'd want to kind of get a little bit more about exposures and kind of tease out those symptoms a little bit more, and then as well as get a little bit more about the patient's history, try and figure out if this is going to be common things being common, or if we're going to have a more require like a more involved differential diagnosis.
Yeah, I agree with everything that Eli just said. I think the point about with a young patient, really thinking about their either exposures that could be unique or their risk factors are the two key things that I always listen for in a presentation. So that's what I'm going to be anxiously waiting to hear about. We've already heard about the past medical history, but whether there are any unique exposures for this individual that could put them at risk as well.
Perfect. So, Youssef, do you have any interesting exposures to tell us about here?
Ask and you shall receive. So on exposures, she actually lives 2 hours north of Atlanta, works at a fast food restaurant, has recent travel to Houston, Texas, without any notable outdoor activities or hiking or cave exploration or anything like that. She has 2 cats at home with no other animal exposure, no recent dental procedures, no history of IV substance use or smoking or alcohol or any other substance use for that matter.
I guess, Eli, just before you go on here, just to kind of, I'm sure you're about to do this elegantly here, but a lot of information was kind of provided here. And a lot of times for learners in the hospital setting, when a question is asked, sometimes there's a disconnect for like, oh, why is that question being asked? Could you kind of run through some of those exposures and talk about maybe like why some of those questions were asked?
Are you asking for me or for Youssef?
Oh, for you, for
Okay,
you as
sorry.
our expert discussant. Yeah.
Yeah, of course. So I think, for thinking about different exposure histories, when we think about, different infectious disease, certain pathogens are only found in certain environments, and, certain exposures, and we associate, exposures with those environments with an increased risk of those infections. And the, living north of Atlanta, or kind of getting into a little bit more, rural area, you might see you might think a little bit more about like tick-borne diseases or things like in the woods up there. Cats we associate with like Bartonella, Pasteurella. Dental procedure is a classic risk factor for a prosthetic valve endocarditis. And then travel to Houston or Texas, not necessarily, not necessarily connecting that to this case. I guess I want a little bit more about like when that was relative to when symptoms started.
That was about 2 months prior.
Yeah, and I think that, in addition, what we're thinking of here is either probably some type of cardiac or pulmonary syndrome, just given the how focal things are. So when I think about pulmonary disease, infectious pulmonary diseases, things that come to mind are things like, either tuberculosis, right, could cause some of these symptoms. Often it's going to be a more chronic thing, but it has to start sometime. Atlanta has a lot of tuberculosis around. So definitely kind of keying in on, where somebody's been living and if they've traveled to endemic areas. But then thinking about a lot of the fungal diseases as well, because if you don't think about them, you're not going to test for them. And so I think that that's another thing that the travel history can help us think about, things like histoplasmosis or cocci or blastomyces, and then all the normal kind of pulmonary pathogens aren't necessarily going to be related to any particular exposure history. But then, like Eli said, really thinking about other exposures. So if we're thinking about a cardiac issue or some type of prosthetic valve, either abscess that's formed around there, endocarditis or something like that, that could be leading to these symptoms. Then the exposures of cats, Bartonella is something that we can see that can cause that. And the dental procedures would tell us about different types of pathogens, like strep that we would more typically see.
Very interesting. Youssef, do you have any other information to give us for this kind of past medical bucket, and maybe we can move on to the vitals and the physical?
On notable HPI, she initially presented to a neighboring hospital with these symptoms exactly. Blood cultures were collected, a chest X-ray was done at the time that showed increased interstitial markings. The patient was discharged from the ED on ceftriaxone and azithromycin. She was discharged home, but then in the interim, developed the fevers and chills, and that's why she represented to our hospital. The review of system was notable, as we said earlier, for the fevers, chills, and some night sweats. Other past medical history is notable for hypertension, and then, as I said, the aortic valve pulmonic stenosis and the replacements. And then she's had 6 prior cardiac surgeries, most recently 2 years ago. Family history is notable for high blood pressure and diabetes in the parents. I can give you the med list if you want as well right now. So she takes amlodipine, aspirin, warfarin, and carvedilol, and doesn't have any allergies.
Okay, so I think there's a lot of useful information in this aliquot. And this is, something that's pretty common for us for infectious disease is we're inheriting a patient who's been worked up at another institution or in another setting, and we don't have complete access to all the records. Like, it'd be really nice to, have the chest X-ray and sort of all those things, but we can make the inference based on the way that they treated the patient that they thought she had community-acquired pneumonia. So ceftriaxone and azithromycin kind of tells you what the providers at that institution were treating. And so, I think we want to think a little bit about that and sort of see if, has she gotten any better with that treatment? Was she sent home with continued treatment for community-acquired pneumonia? And has that had any impact on her illness course? And if she hasn't, then we might discount, community-acquired pneumonia or the typical pathogens that cause community-acquired pneumonia as the cause of her present symptoms. The other thing that I think we just learned that's really helpful is that whatever congenital syndrome she was born with appears to have been confined to structural heart disease. She doesn't have any other known past medical history that's suggestive of like an immunosuppressive syndrome, and she's not on any medications that suggest that there's anything going on other than her cardiac history. And so that being the case, I'm going to approach this patient as someone who is in general immunocompetent, but has these risk factors for infection, which namely the multiple cardiac surgeries and the foreign hardware inside her in her bloodstream. The other thing that I think is worth noting there is that her last major cardiac surgery was 2 years ago, and so we wanted to kind of think if she does have an infection related to her to her cardiac devices or to those prosthetic valves, we want to be thinking about other exposures that could have started that process off. A 2-year incubation period is quite long for most typical pathogens.
And Eli, I'm wondering if you can tell me, like, when you're thinking about a syndrome around which you're forming a differential diagnosis for this patient right now, like, what syndrome or syndromes are you considering in your differential before you get additional information? Like, what are your kind of leading potential diagnoses just based on what we have? Yeah,
so I think a good syndrome or, like schema that I'm working through in my head is like, fever plus cough. And when I think about fever plus cough, I generally am thinking about, the primary pulmonary things that we think of. So like, pneumonia, and the different sort of types of pneumonia, which could be, community-acquired pneumonia, which, doesn't necessarily have to have a key epidemiologic exposure. But she's been treated for the typical bacterial causes of community-acquired pneumonia, hasn't gotten better. It could be that she has community-acquired pneumonia that's not from a bacteria. So she could have viral pneumonia, which I think we're all intimately familiar with at this point. COVID, influenza, RSV. So I would want to make sure that she's had high quality testing for those pathogens. And even if they were done at the outside hospital, it's worth repeating. I think we've all experienced, patients who sometimes get tested a little too early in their illness course, and then are positive on subsequent testing. I didn't hear anything on her medical history or her exposure history that really makes like fungal pneumonia, I think, super likely in this case. If we get imaging that's otherwise concerning, or we sort of strike out looking for other things, we may come back and revisit that. And then sort of likewise with mycobacterial causes of pneumonia. Other things that I think about when I'm considering a patient who has fever plus a cough would be other things that can affect the lungs but are not primary pulmonary infections. And so, in this case, you'd think about the potential for endocarditis with septic pulmonary emboli would be one potential cause. And it's intriguing that this patient has so many, artificial heart valves. And so it kind of like is a cue that may be relevant to us later on. And then thinking about non-infectious things, I think about, autoinflammatory diseases, some of which can affect the lungs. So, you can get interstitial lung disease, like it can cause a cough, and you can have, fever from, some systemic inflammatory component. Also think about pulmonary embolism, which can cause both fever and cough.
Mm-hmm.
Perfect. And Youssef, just to round it out, was there any IV drug use noted in this patient? I'm not sure if you said that or not.
And none, no IV substance use or otherwise.
Okay, perfect. Do you want to go through the vitals and the physical exam and maybe like the basic set of labs? I'll let you pace it however you want, but I feel like that may be a good next style of quad.
Yeah, absolutely. So on initial vitals, the temperature was 101 degrees Fahrenheit with a heart rate of 95. The respiratory rate was 18. The blood pressure was 107/74. Her oxygen saturation was 99% on room air. On general exam, she was not in acute distress. She was resting in bed. On HENT, so she was positive for conjunctival pallor without any scleral icterus. On cardiovascular exam, she had a regular rate and rhythm with a 3 to 4 holosystolic mechanical murmur, along with a decrescendo diastolic murmur at the right upper sternal border. We did not see any increased JVD or increased JVP, and no peripheral edema. Her lung exam was clear without any wheezes or crackles. Her abdomen was soft and non-tender, and her extremities were warm without any rashes on any of the extremities or face or trunk for that matter. On basic labs, I think the white blood cell count was 4.0. The hemoglobin was 9.5, while the platelet count was 264. On the chemistry, the sodium was 136, with a potassium of 4.0, chloride of 103, bicarb of 24, BUN of 6, and a creatinine of 0.52. I can go on for extended labs if what do you think, Andrew?
Maybe if you don't have a hemoglobin baseline, maybe just like a rough estimate, like unchanged or like down, and then maybe the LFTs too, I think would be helpful here. Yeah.
The hemoglobin was 12.5 4 months prior, and the MCV is 81.5. And then other labs, we had the AST and the ALT were within normal limits on liver chemistries. I also have iron studies if you want them now. The ferritin was elevated at 257. Iron was elevated at 35. The T-Billy total to direct was 1.3 to 0.7. And then I have a rheumatoid factor that is positive at 4.6.
Oh, okay. That's
All right.
yeah. Anything else, Youssef, or was there one more?
The BNP was normal.
BNP. Okay, perfect. All right, you got a lot there, Eli.
Yeah, no, that's a lot of good information. So I think let's look at the vitals and the exam first. Again, going back to the fact that this is a young patient, you always kind of want to figure out like how did this patient get through the ED? Like, how did they get admitted? And there's nothing sort of on the vital signs necessarily that tells you like why this person would need to be admitted. It doesn't sound like they have a lot of respiratory distress or anything that's super concerning based on their exam. Now again, congenital heart disease plus fever may be enough to buy you admission based on what institution you're at, or just based on comfort level, or the fact that she's had a workup at a previous hospital and hasn't responded to initial therapy. But I think it's comforting to know that this patient appears to be hemodynamically and stable from a respiratory standpoint, at least initially. Going through the exam, we have the conjunctival pallor, which we have a lab correlate for shortly thereafter. Thinking a little, and then moving on to the cardiovascular exam, we have these murmurs, but in the segment for congenital heart disease and the multiple valve replacements, it's hard for me to really know. Unless I knew this patient very well myself, I think it'd be really hard to know if any of these murmurs are new or in any way changed from her baseline. What I did not hear was any evidence of vascular or immunologic like stigmata of endocarditis based on the physical exam. So no like Janeway's lesions, no Oster nodes, nothing that sort of supports the evidence of systemic emboli or immunologic manifestations of endocarditis. So that's kind of what I'm taking away from these. And then also the pulmonary exam was clear. So I'm discounting, I think, pneumonia a little bit on the basis of the physical exam. But we'll kind of come back to that when we look at imaging. Moving on to the labs that we've had, the striking thing on the CBC is the change in the hemoglobin from baseline. In someone who has a mechanical valve and is on warfarin, I think it's important to consider whether or not this could be due to just hemolysis, like destruction of the RBCs in the valve. And so I think it would be the bilirubin is not that high, but I think checking a haptoglobin could be useful. And then also thinking about the possibility of bleeds in someone who is on systemic anticoagulation. So wanting to check what the INR is, and then making sure that on a review of systems, we've asked for any evidence of occult blood loss, especially through the GI tract.
Yeah, and I think a couple things I would add here is I agree that the murmur is something I definitely pay attention to. And, I always try to look at prior documentation of murmurs to see what's in there, or ask people, especially if you're at an institution like at our university hospital, we often have our congenital patients followed by the same providers. And so would be able to say if this is something new. But if I see a fever and a murmur in somebody with congenital heart disease, especially with prosthetic valves, and I don't have a localizing place of, it seems like pneumonia is less likely, like this is endocarditis until proven otherwise, and requires a workup for that very quickly. I think that the hemoglobin being decreased with the total and direct bili a little increased also makes me wonder, like, is there hemolysis going on, like something related to the valve, or is this hepatic congestion? And even though the BNP is normal, making something like heart failure a little less likely, if it's more acute, you may not see a huge change all the time. So is there some mild, hepatic congestion there? Eli, I'm interested, what do you make of the rheumatoid factor?
I would query a little bit of why it was sent. I'm not really, that was not something that was sort of part of, what I'm thinking about yet at this point. So rheumatoid factor is a pretty non-specific marker of immune activation and sort of in my mind. And so, I don't really make too much of it one way or the other. I mean, if this person turns out to have infective prosthetic valve endocarditis, I would say it's related to the systemic inflammation from that. If we end up finding that this is something else and we start going down a non-infectious endocarditis pathway, it could be, again, a marker of a systemic autoinflammatory disease. But
Yeah, no, I completely agree. I think, a lot of things like rheumatoid factors and ANCAs and things like that are often seen, and it makes people think of a specific autoimmune disease, when in fact, they're just often signs that there's some type of immunologic process going on, which could be infectious or non-infectious. So it's something on the ID service that we commonly see as positive and sometimes pushes people down the wrong direction. So I just wanted to call that out before we move on.
Yeah, and so I'll take off of one of the things that Jen said, this is infective endocarditis until proven otherwise, and I agree with that in the saying of fever. We're going to get our own chest X-ray and be able to reveal that, but unless we kind of come up with a clear alternate diagnosis, like we look at our chest X-ray and we see something that's pretty convincing for pneumonia, fever without a clear localizing source in the patient with this history needs to be thought about as likely or possible endocarditis, and we would start moving down that treatment pathway. We do have the advantage of the blood cultures that were collected at the outside institution that are hopefully 24, 48 hours ahead of wherever we are right now. And so one of the most important things that we can do on the day that we first meet this patient is calling the micro lab at that other institution to try and get whatever information is available.
That's perfect. Youssef, do you have any blood culture data from that prior hospitalization?
Yeah, I actually, Eli, that's exactly what we did. We went ahead and called the outside micro lab, and the cultures from that hospitalization were no growth to date at 4 days, and then blood cultures at our institution were also negative.
Gotcha. So, and do we know whether or not the blood cultures at the outside hospital were collected before the patient got any antibiotics?
They were collected before antibiotics.
Okay, and we know, and so what we're moving towards is, again, we still need to do our own imaging, at our institution, chest X-ray look for pneumonia, maybe a CT scan, and then some echocardiography. But if we're going to start thinking about endocarditis, we sense that we may be moving towards a culture negative endocarditis pathway, or at least thinking about that a little bit. And when I think about culture negative endocarditis, Varun Fadke, who's one of our ID clinicians here and does a lot of, I've learned a lot from, kind of helps us think about that in sort of three ways. So culture negative endocarditis, you have patients who, what he calls, should be culture positive endocarditis. And so that's basically your typical bacterial pathogens, but we gave them antibiotics before we collected the blood cultures. And so when you're evaluating for this, you need to just make sure you have a really good history, looking at timestamps of cultures collected, when antibiotics were given, and also making sure that they didn't take some leftover augmentin that they had laying around from like a sore tooth because they felt bad for 2 days before they came to see you in the hospital. This patient in particular, right, is a setup for oral, strep viridans, prostatic valve endocarditis. They took amoxiclav for several days because they felt bad. That absolutely could have sterilized their blood cultures and not let you grow that strep viridans when you have your blood cultures. The second group are things that can be grown in blood culture. It's just really, really hard. And so that brings you to, some of the things that we have other tests for that are better than our, like standard blood cultures. And so that's like looking at things like our serologies for like Bartonella, Coxiella, Brucella. Some of those have PCR-based tests as well. And then finally, there are the things that you'll never, ever grow. And so that would be things like Aspergillus, or the thing that causes Chagas disease, that you're just never ever going to grow, that you have to diagnose by other means. And then finally, if you can't find one of those things, you move on to non-infectious causes of endocarditis, and we can kind of explore that a little bit as well. But that tends to be malignancy or autoimmune related. Although in this patient, I would consider again, complications maybe of the mechanical valve. Like I think you can just get clot formation like in these mechanical valves and then have that go out and cause problems. And so I'd like to know, I don't think we've talked about her INR yet. So if we had access to her INR history over time, that would be something that would be meaningful information if we move farther down that path.
Any other thoughts, Dr. Spicer? That was great, Eli. that was awesome. I think you covered all the big culture negative endocarditis. Just to like lay the land, I guess, really quick, a question from my end. Like, what's the epidemiology of all of that culture negative list? Because you listed like Brucella, Coxiella, Bartonella. Like of those, kind of what's the most common?
Yeah, so those are the classic ones. And so the classic associations are Brucella with like the Mediterranean basin and like unpasteurized milk, cheese. Coxiella, like Q fever, like livestock, and then Bartonella, cats, and to a lesser extent, dogs. But in particular with like Coxiella and Brucella, a majority of patients who end up with those diagnoses don't have the relevant epidemiologic exposure. And so the exposures are useful for like piquing your interest, like when you're seeing a case like this, and they're certainly useful for testing scenarios. But in clinical practice, you have to have a high index of suspicion, even if the relevant exposure is not present in your case. Most of the literature on culture negative endocarditis, I think, or at least a lot of it, comes from France, and they seem to have a lot of Coxiella in France. Whether or not that applies to other places, I don't know. But when, we have a weekly case conference here, and culture negative endocarditis, makes the cut a couple times a year. And we always hear the same things about there being just a bunch of people with Coxiella, but again, they're all from France, so hard to know.
Yeah, I would just add, I think, both Coxiella and Bartonella are the two most common in most of the studies that have been shown. But I agree with Eli, most of it's literature from France, and obviously the epi there is a little bit different, but in larger studies looking at culture negative, those are probably the two most common. And, I always get a social and exposure history. I never trust an exposure history. It's not that the patients are lying to us, but it's really hard to remember stuff, especially things that may have happened, a month or more ago. So, although I get that some people rely on that for testing, I never rely on that. I use the syndrome to decide what I test for. And then I always think about the most common causes. So in all my patients who I suspect endocarditis, I'm going to send off Coxiella, Brucella, Bartonella. And then even consider sending off other stuff too, because it's often that patients don't really know, don't recognize that they've had exposures, or they're like, oh yeah, there was that kitten a month ago that I played with for 30 minutes that maybe scratched me, once you go back and talk to them and have a diagnosis. So again, I just kind of move on and just go through my workup. And honestly, for this patient, besides chest imaging, I'm waiting to know what's the current echo and how does that current echo compare to the old echo, right? Because there may be valve abnormalities, and, patients may have, patients who have valve replacements don't always have a normal cardiac exam or a normal echo. And so this is where going and talking to the cardiologist who's reading the echo in the echo room with them is incredibly important. In ID, we always go and talk to people who did imaging in cases where we don't know. There is nothing that can replace that. Reading a report or even looking at an image on your own is not enough.
I love doing that when I'm on the ID service. It's always so much fun. And I guess segueing off of that, Dr. Spicer, could either of you talk a little bit about Duke criteria? And I think you kind of talked about how the echo aspect of the Duke criteria would be very complicated in this patient, but could you also talk about the culture negative endocarditis aspect of the Duke criteria, which would be a little bit different in a patient like this?
Yeah, so the Duke's criteria helps us assign probabilities for endocarditis. You've got culture-based criteria, which Coxiella serology is actually now one of the major criteria. So if you have Coxiella serology that's positive, that can replace being culture positive, because you're not going to throw Coxiella in culture. And then so that's kind of sort of, I guess, the main thing when you're thinking about culture negative endocarditis, that the Coxiella serologies are incorporated into the two criteria. For the other ones, it's really just about your index of suspicion, which is going to be driven by the clinical syndrome. Are you trying to connect, do you have evidence of multiple embolic phenomena that are coming from a central source, and that's kind of driving your suspicion for endocarditis? Or do you have an echocardiographic finding that you're trying to explain? Yeah.
To be honest, I find a lot of these kind of criteria and risk factors to not be super helpful. They're really helpful for research, and that's how most of them were originally developed, to help with classifying people for research studies. But I find that really kind of your clinical impression of a patient is more helpful. So I look at the Duke criteria more to be okay, here are the things I need to make sure I'm thinking about, right? Am I thinking about their echo, their blood cultures, IV drug use history, and things like that? But I never, when somebody's presenting to me, I don't expect them to tell me about the Duke criteria, to tell me where they classify as, because I find that the story from the patient ends up being much more helpful. So I think that as progressing throughout training, a lot of these classifications and criteria, I think, become less helpful over time, if that makes sense.
I agree with that.
I love it. Perfect. All right, Youssef, what do we got next?
So just to complete the labs that we didn't say earlier, the haptoglobin was less than 12. The TSH was within normal limits, and HIV antigen antibody was negative. As you all were thinking, we got a TTE. On the TTE, there were multiple instances of regurg that were not new, but the prosthetic pulmonic valve was not well visualized. So they proceeded to get a TEE, which showed a small mobile mass associated with the prosthetic aortic valve, suspect suture, but a vegetation could not be excluded. Clinical correlation is required. I can give you some interval history in the meantime. So in the meantime, the primary team started the patient on empiric coverage for endocarditis with vancomycin and ceftriaxone. And the patient's symptoms had resolved completely. She was doing okay. She basically felt completely back to baseline. And at that point, I'm going to leave that to you to discuss, or what would you do at this point?
Sure. And so while let's tease out a couple other pieces of information that would be available at this time point. So did the patient take did the patient leave the other hospital with the other antimicrobials? And so was the patient on anything in between the time they left the other hospital and came to see us?
Yes, I believe she was on Augmentin and Azithro just in the couple of days between. So went to the ED and just got ceftriaxone and azithromycin, was discharged on Augmentin, went home, had fevers and chills, and came back to us essentially.
Okay. And what testing for respiratory viruses was done when this patient got to Emory?
So when she got to Emory, she just got a chest X-ray initially in the ED. That was clear, and then she was admitted to the cardiology service.
Okay. But respiratory virus testing. So did she get the full respiratory viral panel, just a COVID? What viral etiology?
Just the screening admission, COVID and influenza screening essentially, but no other respiratory viral panel.
And I'm presuming all of those were negative.
Yes, correct.
So I think it's interesting. So we have this patient with a, again, the multiple prosthetic heart valves, who's coming in with a week or so of fever that did not respond to ceftriaxone, azithromycin, Augmentin, and then comes in and gets vancomycin, ceftriaxone, and then gets better, and then has this small indeterminate mass on the aortic valve that could be a suture, but could be something. So I think two things that I would want to do in this situation, because one is like Dr. Spicer was mentioning, is going and sitting down with the cardiologist and reviewing this TEE and trying to see how best we can decide, was this there before? Right? Because there being a new mass versus there not being a new mass kind of really, I think would mean a lot in this patient. If there's evidence that this is sort of like an old suture material, you might discount the possibility of this being endocarditis. The other thing is worth doing is sort of really getting a good understanding of when the patient started to get better relative to when the current antimicrobials were started, right? The ceftriaxone is the same as what the patients were receiving before they came to the hospital and was not getting better. And then the vancomycin is really just giving us MRSA coverage and maybe some better coverage of coag-negative staphylococci. And so, we have not really expanded our spectrum of coverage that much compared to what the patient was getting previously. And so I think it's worth thinking about whether or not those antimicrobials are what caused the patient to defervesce and get better, or whether or not it was just time. And so that's why I asked about the respiratory viral testing. So if I were seeing this patient as a consultant, even if they were feeling better, I would be swabbing them and getting a respiratory viral panel, hoping to just find some leftover nucleic acid. Because if they had rhinovirus or adenovirus, that would also maybe be another marker against this being endocarditis. Because I would have an alternate explanation. If we are really worried about this patient having endocarditis, another thing that we could do, or if we go and we talk to the cardiologists and we're not really able to get a clear answer as to what we're seeing on this echocardiogram, prosthetic valve endocarditis is a setting where PET scans can be very useful. So doing an FDG PET in this patient and looking for increased metabolic activity around the aortic valve could be really useful for trying to decide if that's a metabolically active lesion, more suggestive of endocarditis, versus if it's just, suture material, you wouldn't necessarily expect that to be metabolically active. And then not necessarily going to be the answer in this case, or I'm not sure this relates to our diagnosis, that low haptoglobin makes me think that maybe the hemoglobin drop we've seen might be related to, red blood cell destruction related to the valves or something like that.
Yeah, so I think just a couple teaching points I would make here. In a patient with prosthetic valve endocarditis, they have to have a TEE. And so a TTE, I think, is quick, can often happen first. And so we get it. It can be helpful as a comparison because we're not doing TEEs all the time in patients. So I think that is a helpful first step to have comparison windows to prior, but getting the TEE was required no matter what. And the fact there's something on the TEE, like, honestly, unless you can convince me this patient has something else, like, they will get treated for endocarditis. But I agree with Eli that a PET scan is super helpful in this. But again, you're kind of going with risk benefit. And if I can't get another explanation for what's going on with her, then it really makes me worried that she has some type of endocarditis. And I think she needs a full culture negative endocarditis workup at this point.
All right, Youssef, are we close? Is this the last aliquot, or you have two more for us?
Yeah, absolutely. So this was like exactly what Eli and Dr. Spicer are mentioning, how hard it is sometimes to figure out the diagnosis. In this case, the patient was feeling great, and our working diagnosis was endocarditis, and didn't go completely match our illness script for endocarditis, basically. So the infectious disease team was consulted. We went to radiology and we discussed it with the radiologist, and we discussed whether this is a suture or vegetation. And this was difficult even for radiology. So we had to have a multi-conference team with congenital cardiology, adult congenital cardiology, radiology, and ourselves. And we had to discuss what to do next, essentially. And we opted to do a PET CT scan. The PET CT scan showed a area of increased uptake in the aortic and tricuspid valve, strongly suspicious for an infectious/inflammatory etiology in these regions. Otherwise, no significant findings.
Yeah, so I think that's really helpful. So again, I think not all positive PET scans are infectious etiologies. Any sort of cause of increased metabolic activity, so autoinflammatory disease, could do this. But or just even if the suture of the suture was causing a local immune response, that could theoretically cause a positive signal in the PET scan. But I think given the constellation of findings that we have and the risk of being wrong, we have passed our threshold for treating this patient for culture negative endocarditis, and so she's going to get a treatment course for that. The question then is what to treat her with. It seems like vancomycin and ceftriaxone caused her to effervesce and feel better. it's worth thinking a little bit about why that would be. So vancomycin ceftriaxone is, a pretty standard regimen for culture negative endocarditis. But if we go back to that model of the 3 different buckets of culture negative endocarditis, should be culture positive, things that can't be grown in blood cultures, and then things that never grow. The vancomycin ceftriaxone is geared towards bucket number 1, which makes sense because that's by far the most common, right? That we don't think about endocarditis until late. Patients have already gotten blood cultures. The vast majority of culture negative endocarditis is caused by typical pyogenic bacteria, Streptococcus, Staphylococcus, haystack organisms. And we're just not growing them because the patient got blood cultures first. So if that's, if vancomycin ceftriaxone is all that this patient needs, then that's probably something from that bucket. And the only thing that wasn't really being covered by the antibiotics ahead of time was, staphylococcus, some resistant staphylococci, which, is possible in this patient. For bucket number 2, wouldn't necessarily have expected the patient to get better on vancomycin ceftriaxone. We typically use doxycycline to treat most of the things in that bucket. But, I think, so you could consider adding doxy to your regimen while you wait for serologies, while you wait for sort of your other diagnostics to come back, your Coxiella serology. Bartonella has a PCR, which is, I think, a little bit more useful than serology. And so you could, while you wait for those things to come back. And then in bucket number 3, we haven't really had any of the epidemiologic exposures that make me think about those things. The one thing that I did not mention earlier, which goes a little bit more into bucket 2 than bucket 3, though, is in patients who do have a history of cardiothoracic surgery, is the possibility for Mycobacterium chimera infection. There was an outbreak of Mycobacterium chimera endovascular infections associated with cardiothoracic surgery several years ago as a result of contamination of heater cooler units in the ORs. And so that is something that I think is maybe more relevant for ID boards than general medicine boards, but it's something that that does come up from time to time is thinking about that. So I think, it's reasonable to, continue this patient on the vancomycin ceftriaxone that she got better on, plus or minus adding doxycycline while you wait for your culture negative workup to come back.
I don't have much to add. So being cognizant of time, I was gonna let Youssef go ahead unless there's a specific question that y'all want me to address and add on to Eli.
That sounds great. I think we had a really comprehensive discussion. Let's hear from Youssef on what we ultimately found.
Eli, do you want to put your nickel down, or if you want to put your nickel down on one, which one would you guess?
I mean, I think common things being common. So, I mean, this lady has cats, right? And I'm a dog person. It's always fun to bash on cats. So it would be fun if it was Bartonella. But I think common things being common, I'm going to say that we never identified any etiology. She got a duration of vancomycin ceftriaxone and continued to be better.
Yeah. So unfortunately, the cats win again. So the Coxiella IgG was negative. The Brucella antibody was negative. However, the Bartonella IgG was positive at 1 to 1024 dilution. And this was a case of presumed Bartonella culture negative endocarditis.
That's really interesting. And it's, again, always fun to bash on cats. So the Bartonella also has a PCR available. Was that ever sent for this patient?
So the PCR was not sent. Surgery was considered, especially with given the endocarditis. We discussed it with CT surgery, who considered that given the patient already has a history of 5 prior surgeries and was clinically stable, we opted to continue her antibiotics. She was actually discharged from the hospital on doxycycline, rifampin, and gentamicin. She actually followed with infectious disease clinic and got a repeat PET-CT scan that showed resolution of the inflammatory area on their valves, and still following in clinic up to this day.
That's awesome. That's a really fascinating case. I think the one teaching point that I'll throw in for Bartonella diagnostics, one is not just the availability of the PCR, but that, one thing that's becoming increasingly common is the use of like 16S ribosomal sequencing or carrier testing, things like that. These sort of just broad range, like sequencing based approaches where you don't have to know what you're looking for when you order the test. And it's worth knowing that for when you do have a specific test like the Bartonella PCR, that is more sensitive than the 16S ribosomal sequencing. So if you were to take this patient to surgery and to get tissue, you would want to send both Bartonella PCR on that tissue as well as the 16S ribosomal sequencing, because the Bartonella PCR is going to be better at finding Bartonella than the 16S approach. And so I think that's a nuance that's worth knowing, because sometimes people assume, oh, if it tests for everything, it tests for everything, but it doesn't have the same yield as the dedicated test. And that's true for a lot of the syndromic things that test for many things, like the biofire meningitis and encephalitis panel. Some of those individual targets aren't as good as the standalone tests for those diseases.
Perfect. Thanks so much, Eli. Anything else from you, Dr. Spicer?
I don't think so. I know we're close to time, and I can't remember if Youssef had a teaching point or something that he wanted to share at the end, so I don't want to steal his thunder.
What I was going to share was very similar to what Eli said. We do have the same teachers and same professors, so we're learning well. I learned to use the framework that Dr. Fatki taught us. Should have been called culture positive, could be culture positive if you try really hard, and will never be culture positive. I'm not going to repeat them now just because Eli sent them so succinctly. I'm going to link to a podcast that Dr. Fatki was on that was fantastic and mentions all of the above. The other thing I would add is that I'm a huge fan of CP solvers, and I listen to RLR every day. They have a episode on culture negative endocarditis, and the differential for them was PCCCC. So it was POTH, clot, cancer, or calcium. And this case taught me a new item, which is a suture, which is an S to add to that mnemonic.
PCs, I love that, Youssef. Also, that's a great febrile podcast episode. Thanks for sharing that with everybody else. Thank you all for coming. Also, thanks for giving us the follow-up on that case, Youssef. That's a very interesting case. I actually have never seen a case of this myself yet. This is an awesome presentation, a very tough diagnosis to make if you don't know about it. So I'm sure all of the future cat owner patients out there will thank you when we catch this next time. Maddie, I think you're signed up for teaching points. Do you want to go through it really quickly and close it out for us?
Yes, definitely. Well, first of all, I just want to say, Youssef, Eli, Jennifer, that was really a phenomenal case and such incredible teaching. So as you can see, I did not have enough room for the teaching point, so I'll kind of go through what we have here. So right at the beginning, we learned that this was a young patient, and we kind of talked through why would this young patient be sick enough to be in the hospital, and really that you want to think of, are there any unique exposures or unique risk factors? And in this case, the risk factor was really the congenital heart issue. And Eli walked us through the question of, were there any other features of this congenital syndrome? But ultimately, we learned that the syndrome was confined to the structural heart disease. And we learned that there were no signs that this was an immunocompromised patient, but rather this was an immunocompetent patient with risk factors for infection, namely the cardiac surgeries and the hardware. We talked about the importance of exposure histories because pathogens are located in different places. So, different associations, like if a person has been in the woods recently, you want to think of tick-borne infections. Cats, in this case, you want to think of Bartonella. Dental procedures, you can think strep endocarditis, and travel history, you can think of endemic fungi. And then when we got to, even actually before the physical exam, we were considering infectious cardiac and pulmonary syndrome. So for pulmonary disease, we talked through TB, fungal disease, typical pulmonary pathogens. And then for infectious cardiac processes, we talked about valve abscesses and endocarditis. And then Eli walked us through the differential for fever and cough. So we talked through both primary pulmonary processes. So this could be, a bacterial pneumonia, but this was less likely because the patient did not improve with treatment for that. Viral pneumonia, fungal pneumonia, mycobacterial causes. The differential also includes endocarditis, then non-infectious causes like interstitial lung disease. Ultimately, when we got the physical exam and we saw that there was a fever, murmur, and congenital heart disease, we said that this was really endocarditis until proven otherwise. And we talked about in the workup of that includes blood cultures before antibiotics, and then sending off Coxiella, Brucella, Bartonella, and then an echocardiogram, importantly, talking to the radiologist. And then Eli walked us through this really helpful approach of culture negative endocarditis. And this really falls into three buckets. So the first one is that it should be culture positive. So these are typical bacterial pathogens, but perhaps the patient got antibiotics before blood cultures were drawn. So an example of this is, say, someone took a Moxclav for strep viridans endocarditis. And a way to make progress of this is you really want to get a good history about which antibiotics the patient has taken and when. The second bucket is that the organism can be grown in blood culture, but it's just really hard to. So these are things like Bartonella, Coxiella, Brucella. In terms of some epidemiology, Brucella is generally in the Mediterranean basin or unpasteurized milk, but notably patients don't always have these exposures. But so you could also think of Coxiella with livestock and then Bartonella with cats and dogs. And then Dr. Spicer taught us that the Coxiella and Bartonella are actually the most common of these. And then a little fun fact in that with CT surgery history, you also want to think of Mycobacteria chimera. And then the last bucket is organisms that will never be culture positive. So that's an example of that is Aspergillus. We talked about how Duke's criteria is helpful to assign probability for endocarditis, but really the clinical syndrome and the patient story may be more helpful than these criteria and classifications. We got to prosthetic valve endocarditis and we learned that patients definitely need a TEE in this case, and also PET scans can be useful to look for increased metabolic activity. So an active lesion on the scan is more suggestive of endocarditis versus no activity is more suggestive of like suture material. And then lastly, treatment for culture negative endocarditis. Usually the standard regimen is vancomycin and ceftriaxone, usually for that kind of the first bucket that we talked about. For the second bucket of bugs that can be grown in culture but hard to, it's usually doxycycline, so you can add that while you wait for the culture negative workup. And then lastly, we learned a really interesting pearl on Bartonella diagnostics, that the PCR is available and it's more sensitive than the 16S ribosomal sequencing. So you'd want to send both if you're concerned with that. All right, those are all the teaching points. Thank you, everyone.
Well done, Maddie. That was an awesome summary. Thank you all for coming. We appreciate you being here. Come hang out with us in the future, okay? Good to see everybody.
Thanks for having me. I'm gonna run watch the game.
Have fun. See you.
Imagine.